Thank you. Is it mouse button or is the green one? Either one. Okay, perfect. Good afternoon. Thanks for everyone being here on Saturday this late. My name is Arielle Perez, and I'm going to go over what's new with synthetic mesh. I have nothing to disclose, but I do want to have a little disclaimer. This presentation will be using commercial names or mesh products for specificity and to highlight specific meshes which were used in studies. So in 2000, Lewandike et al. Described the results of their randomized control trial, which compared suture repair with mesh repair for incisional hernias. And with the 3-year cumulative rate of recurrence, they found that 43% of primary suture repairs recurred, and only 24% of mesh repairs recurred. And in 2004, with their follow-up for long-term recurrence rates, their 10-year cumulative rate of recurrence was 63% for primary suture repair and 32% for mesh repair. So with these studies and multiple studies after that, we've kind of made it fact that mesh repair reduces the incidence of hernia recurrence by almost half. But it's 2022, and we're still seeing patients in our clinic with bulges that look like this. We're still getting hernia occurrences. So is there anything new that's coming out to help us? Let's look at things that are specifically new for synthetic meshes, specifically in regards to contaminated hernia repair, mesh weight, and barrier-coated meshes. So when we think about meshes, there's really 3 main categories. There's permanent synthetic mesh, there's biologic mesh, and there's absorbable synthetic mesh. Luckily, we're going to go over all 3 of these today, and specifically, I'm going to look at permanent synthetic mesh. This is the most used prosthetic mesh for hernia repair. It provides long-term mechanical support to the hernia site. Mainly, there's 3 main materials that it's made of. It's either polypropylene, there's polyester, and then there's also PTFE, or Gore-Tex. In clean cases, most of us can agree that permanent synthetic mesh is the type of mesh that should be used. It's a fraction of the cost of biologic and absorbable synthetic meshes. And there's really no high-level data which demonstrates superior outcomes with the use of biologic or absorbable synthetic mesh over permanent synthetic mesh. So why don't we always use permanent synthetic mesh? It's cheap, it's easy to use, there's good evidence of good results, but I think most of us tend to get a little bit worried of seeing issues like this post-operatively or in clinic. We're worried about the mesh complications, the surgical site infection, the seromas, the hematomas, the bowel adhesions, the mesh extrusion, the chronic draining sinuses, the mesh erosion, the enterocutaneous fistulas. We're worried about that. We've already kind of seen this with the last few talks, that there are issues with mesh. So biologic mesh was introduced in the 1990s as an alternative to permanent synthetic mesh, and absorbable synthetic mesh was introduced as an alternative to biologic and permanent synthetic mesh. But what we know is there's no synthetic mesh, there's no biologic mesh, and there's no absorbable synthetic mesh, which is FDA approved for use in contaminated settings. So we still use mesh in contaminated settings even though it's not approved. Is there any new data for us? Well, in 2020, Warren and colleagues looked at this retrospective single-center review of 402 permanent synthetic hernia repair cases. 53% were clean contaminated, 42% were contaminated, and 6% were dirty cases. The majority of them were done open. They achieved fascial closure in almost 95% of the patients, and the mesh was placed in an extraperitoneal space in 97% of those patients. The mean follow-up for this study was about 46.6 months. And when you look at the patient population, the mean BMI was 32, 27% of the patients had diabetes, 30% were smokers. The mean width of the hernia defect was 9.2 centimeters. When you looked at the outcomes, the surgical site infection rate was 14%. The surgical site occurrence requiring procedural intervention was 20%, and 10 of those patients needed their mesh excised, and 2 of those patients ended up having an enterocutaneous fistula develop. But after 46 months, they actually had pretty good data for recurrence. There was only a 10% recurrence rate. Well, if that's just synthetic, what is it with biologic and permanent synthetic mesh? Well, in this 2021 study that Harris and colleagues published with the Price randomized clinical trial. This was a single institution study looking at 8 surgeons, and this was a pragmatic randomized control trial. It included adult patients, which were scheduled for elective open incisional hernia repair, but they excluded malnourished patients, patients with child's B or C cirrhosis, patients with immunocompromised or steroid use or fecal peritonitis. Patients were randomized to either biologic or permanent synthetic mesh. And the type of the operation was a little bit different. It was really based on surgeon preference. The mesh could be used as a bridge for the hernia defect, or it could be used to reinforce a fascial closure with or without some sort of myofascial advancement flap. Interestingly enough, this study was powered for a goal size of 250, but that was not achieved. They were able to randomize 165 patients, and this was randomization with permuted blocks, which were patients were stratified by their comorbidities, the wound class, and the surgical technique. Follow-up for this study was 26 months. In terms of the patient population between the two arms, they were fairly similar. BMI for biologic was 36, and the mean BMI for synthetic was 35. Approximately about 30% of the patients in both arms had diabetes. 18% were smokers in the biologic group, and 23% were smokers in the synthetic. The mean hernia size was 247 centimeters squared in the biologic group, and was just a little bit larger in the synthetic group, 258 centimeters squared. The majority of the patients in this study, however, were mainly clean cases. When you look at the outcomes, they looked fairly similar, but it was actually surprising how high the SSI rate was. SSI rate for both the biologic and the synthetic group were 39% and 34% respectively. And both the arms required mesh excision in both arms, and they're developing intercutaneous fistula developments. The recurrence rates for both arms, it was 39% for the biologic group and only 22% for the synthetic, but then when you actually stratified it out by just contaminated cases, it was 50% recurrence rate with the biologic group compared to 6% recurrence rate in the synthetic group. Most recently, this year in JAMA Surgery, Rosen and colleagues published their prospective multi-center randomized controlled trial looking at biologic mesh versus synthetic mesh. Specifically, they looked at stratus mesh against barred soft mesh. This was in open ventral hernia repairs with retrorectus mesh, and they were able to enroll 253 patients, 127 in the biologic arm and 126 in the synthetic arm. They had a 2-year follow-up of 97% of their patients, which is pretty good. And when you look at the operative details, between both arms, they were fairly similar, even in terms of the types of contamination. And when you look at the patient population, the patient comorbidities were also fairly similar. BMI was 32 in both arms. Diabetes was in 28% of the patients with the biologic group and 23% in the synthetic group. Interestingly, in their study, they looked at any history of smoking. So it was 64% in the biologic group and 67% in the synthetic group. And the majority of the patients had some sort of posterior component separation. When you looked at the hernia size, it was comparable, 14 centimeters wide in both arms. And again, these were all CDC wound class 2 or 3. And when you look at the outcomes, biologic actually did worse in terms of SSI, SSOPI compared to the synthetic meshes. There was one mesh excision that was required in this study, and it was only in the biologic arm, and there were no enterocutaneous fistulas that developed. The 2-year recurrence risk in this study was 20.5% for the biologic group and only 6% in the synthetic group. So when you look at these 3 trials and you look at this information and you kind of look through it individually between the biologic and the permanent synthetic meshes, it kind of distills down to seeing that synthetic mesh, specifically large pore monofilament polypropylene mesh, placed in the retromuscular space has improved, if not similar outcomes to biologic mesh in contaminated ventral hernia repairs. Specifically, when you look at recurrence rates, it looks like synthetic mesh definitely does have a leg up on biologic mesh. But when you look at all of the studies, there's still going to be complications, whether it's synthetic or it's biologic mesh. There's still going to be a high rate of SSI, and we can see there's a risk. there's going to be enterocutaneous fistulas, and there's going to be need for mesh excision, whether you put a permanent synthetic mesh or you put a biologic mesh in. Well, what about mesh weight? What's new with mesh weight? Is there any information? So mesh weight is based on the American Society for Testing and Material terminology. It's measurement of the heaviness of material, and it's measured based on the weight per unit area. It assumes the thickness of mesh is negligible. The problem is classification systems for mesh weight are controversial and they're variable. Here's a general schema of looking at lightweight, medium weight, and heavyweight mesh. This was published in 2018 in the Journal of Plastic and Reconstructive Surgery by Cobb et al. Really, mesh weight is based on mesh specifics. Filament, textile structure, and pore size, and all of those factor into the mesh weight. In general, you can kind of think of it that meshes with reduced material content and larger pores reduce inflammation and promote improved tissue integration. And so, in this 2021 JAMA surgery trial published by Dr. Kirpata and colleagues, this was a prospective, multi-center, randomized control trial looking at medium weight versus heavyweight mesh in ventral hernia repairs. And specifically, this was medium weight versus heavyweight mesh, polypropylene mesh. And because it was a multi-center trial, they used different types of meshes based on what was available at the hospital. They looked at open ventral hernia repairs with defects less than 20 centimeters in clean cases. And they enrolled 350 patients, 173 in the heavyweight mesh group and 177 in the medium weight mesh group. The baseline characteristics of the patients were all fairly similar. And there was no significant difference in any of the baseline characteristics for these patients. When you look at the outcomes, they looked at 90% of the patients for 1-year follow-up, and they found that there was no difference in 30-day wound and postoperative outcomes. They found that there was no difference in patient-reported outcomes in terms of feeling mesh sensation or pain, and they found that there was no difference in hernia recurrence between heavyweight and medium weight mesh. So it seems like after 1 year, medium weight polypropylene mesh has no benefit over heavyweight polypropylene mesh when placed in a retromuscular space in open, clean ventral hernia cases. What about barrier-coated meshes? What's new with that? Barrier-coated meshes, really it's just an anti-adhesive mesh barrier to reduce bowel adhesions and fistula formations. The barrier coating can be from hydrophilic hydrogels or hydrophobic structures like silicone or PTFE. And usually these meshes are used for intraperitoneal placement up against bowel. Well, every now and again, we do place barrier-coated meshes in protected spaces like the retromuscular space or the extraperitoneal space. And in this 2021 study by Thomas and colleagues, this was a retrospective review of a multi-institutional prospective database using the America's Hernia Society Quality Collaborative. They looked at open retrorectus ventral hernia repairs with synthetic mesh in CDC wound class 1 cases. There was no significant difference in baseline characteristics except for the type of release that was used. The majority of the releases were some sort of posterior rectus sheath or transversus abdominis release. They looked at over 3,600 patients, and they did propensity score matching to evaluate outcomes, so in a 2-to-1 propensity score matching. And what they found was an increased rate of surgical site SSOs and SSOPIs with coated mesh, and the majority of those SSOs were all seromas. Now, in terms of placing that coated mesh in an extraperitoneal spot, this was recently published this year by Ayuso and colleagues. This was a retrospective review of a single institution prospective database, and they looked at open preperitoneal ventral hernia repairs using polypropylene mesh in CDC wound class 1 and 2 cases. There was no significant difference in baseline characteristics of the patients, and they looked at 530 patients. They did a 1-to-1 propensity score matching, and when they looked at coated and uncoated meshes, what they found was an increased mesh and wound infection rate with coated mesh. They also found there was an increased need for IV antibiotics with coated mesh, which is not surprising given the increase in SSI rate. And then they have found that there was an increased wound dehiscence with coated mesh. With wound dehiscence comes a longer hospital stay, so there is increased length of stay with these coated meshes. So it seems that barrier-coated mesh used in open ventral hernia repairs in the retrorectus and preperitoneal spaces are associated with increased wound and infectious complications. So in conclusion, when we kind of look at these newest data in published studies from 22 to now, it seems that the use of permanent synthetic mesh in clean cases reduces the risk of hernia recurrence by half. The choice of any mesh in contaminated cases is debatable, and it does carry risk, but permanent synthetic mesh, specifically large pore monofilament polypropylene mesh placed in the retromuscular space, has improved, if not similar outcomes, to more expensive biologic mesh. Medium weight polypropylene mesh has no benefit over cheaper heavyweight polypropylene mesh when placed in the retromuscular space in open, clean ventral hernia repairs. Barrier-coated mesh is used for open ventral hernia repairs in the retrorectus and preperitoneal positions, are associated with increased wound and infectious complications compared to uncoated synthetic mesh. And all mesh used for hernia repairs have risks. You need to find the optimal risk to benefit ratio, and you must consider during any repair prior to implanting the mesh. And just as Dr. Prabhu had said previously, I would urge you to follow your patient's outcomes, and it's vital to knowing what is the right and the best thing to do for our patients. Thank you.